Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. This is Gurleen Kaur, current internal medicine resident and incoming Cardiology Fellow at Brigham and Women's Hospital. We are back with our CardioNerds Narratives and Cardiology series designed to promote diversity and inclusion because our differences make us stronger. Today, Air Force CardioNerds will be descending into Rhode Island to talk to Dr. James Arrighi. We are so excited to discuss the pathway of becoming a clinician educator in cardiology and are lucky to have a true authority in this area, Dr. Arrighi. As part of this episode, we will review competency-based medical education and discuss subspecialty training in cardiology. And I'm so lucky and honored to be here with Dr. Katie Fell, CardioNerds Academy Fellow and Cardiology Fellow at the University of Michigan. There's no one better to have us lead this episode than Katie with her strong interest in medical education. And I'll pass it on to you, Katie.
Thanks, Gurleen. That's so kind of you. I am really honored to get to meet and introduce a true model clinician educator, Dr. James Arrighi. Dr. Arrighi is a general cardiologist with a focus in nuclear cardiology. Following his graduation in college and medical school from Brown University, he completed internal medicine residency at Washington University in St. Louis, Missouri. He went on to complete fellowships in nuclear cardiology at the NIH and cardiology and nuclear cardiology at Yale. He currently serves as the president and CEO for ACGME-International, an organization which accredits postgraduate medical education programs outside of the United States. Before his work with the ACGME, he served for over 20 years in various roles in graduate medical education. He was the program director for the Cardiology Fellowship training programs at both Brown and Yale. He additionally served as the director of graduate medical education for Lifespan Healthcare System, overseeing all clinical residencies and fellowships within the Lifespan system, including Rhode Island and Miriam hospitals, which are the affiliate hospitals for Brown University. Dr. Arrighi is active in many professional organizations. He is on the board of directors and served as the past president for the American Society of Nuclear Cardiology. And he has additionally served on the certification board for nuclear cardiology. He is a true authority and leader in competency-based education, which is going to be a really big topic of discussion for us during our episode today. He has served on multiple committees with the ACGME and ACC, which have helped establish competency expectations for internal medicine and cardiology training programs. This has included things like committee oversights for the creation of the ACGME specialty-specific milestones for cardiology, the ACGME Review Committee for Internal Medicine, and the ACC Competency Management Committee, for which he has also served as the group's prior chair. What a welcome to the show, Dr. Arrighi.
Thank you so much for that wonderful introduction. You could see me, my face would be turning a little red, but I certainly appreciate being here. It's my honor to address this group, in particular, all the trainees in cardiology or the potential trainees in cardiology out there. And I'm also pleased to represent the little state of Rhode Island, small but mighty as it is. And I'm happy to engage in the dialogue with you today.
Thank you so much, Dr. Arrighi. We're really excited to have you and learn from your expertise. And your background is quite impressive just with the vast roles that you've had within medical education and really represents the many areas that someone can get involved in if they're thinking about medical education within their career, both as an institutional level, but also nationally as part of the ACGME. And as someone interested in med ed, I think I'm really looking forward to kind of hear how your different roles have evolved over time. So I was wondering, to get us started, if you could share with our audience what inspired you to a career in graduate medical education and what has been your journey navigating through this process and the various roles.
Yes, that's an excellent question. It all started very early on in my career as I took my first position as a junior faculty member at Yale. And at that point, I was new out of fellowship, focusing on cardiac imaging, research, clinical medicine, with education not being on the front of my mind in terms of a full career. But I was given the opportunity to be associate program director relatively early in my career. And I thought it would be fun, frankly, to try it. And once I started, then the whole pathway opened up to me. I actually enjoyed it. I guess I was recognized for liking it. And that's half the battle there, is you have to really have a passion or a love for what you do. And that's probably responsible for most of the success that one has in life. I was recognized for being the associate program director, and I eventually became program director. And that one thing led to another. When I eventually moved to Brown, I was recruited to be a program director to help what was at that time a struggling program. And then my career started evolving more on the national level. I would say also, apart from just the positions that I held at my home institution, so to speak, the other thing I did relatively early that helped was I engaged and I took advantage of opportunities that presented themselves in the relevant professional societies in which I was aligned. For me, that was initially the American Society of Nuclear Cardiology because it was a smaller society. It was my subspecialty area. The subspecialty societies within cardiology represent great opportunities for junior faculty or even trainees to get involved, even before you might get involved in ACC activities. And one thing led to another in ASNC, and I was the chair of the education committee in ASNC. So that put me in a different arena apart from what I was doing locally. And then when positions occurred and opportunities to engage in ACC presented themselves, by that time I was connected to the program director community in the ACC. I was involved in ASNC, and you begin to establish a name and people know what your expertise is, and you begin to contribute on a national level. So it was all an evolution, one step at a time, taking advantage of opportunities, finding out what you like to do, and then pursuing it with a little bit of luck thrown in there because you have to have the opportunities. Sometimes opportunities are about being in the right place at the right time.
A lot of what you just said about getting involved in education opportunities in multiple facets, the ways that you were talking about being a program director, we were fortunate to have Dr. Berlacher and Dr. Damp come on as another prior narratives episode, talk about their experience as program directors. And they talked a lot about some of the unique benefits and challenges of that, which you obviously, I'm sure, can relate to really well as a former program director yourself. Also talking about your experience through the ACC, getting involved in education pathways there. But unique to you, and what I think a lot of fellows and people interested in medical education don't think about is medical education opportunities through larger organizations like the ACGME or ABIM or other really large organizations that influence medical education more on a national or even in your case, an international scale, which is incredibly unique. So could you talk a little bit about your role working at the ACGME and what you have found as advantages of this role in influencing medical education, particularly how this is really different from all those things we just talked about being a program director or a director of graduate medical education of a healthcare system?
Well, certainly an opportunity to work in an organization like ACGME or ABIM or some major national organization is in many ways an opportunity of a lifetime. What that means, though, is that sometimes those opportunities by definition are relatively limited, right? There are not that many opportunities to engage on that level. So some of it is positioning yourself so when the opportunities arise, you can take advantage of them, right? And I think that, to be honest, the way that I got engaged in ACGME initially, I was asked to serve on the ACGME Internal Medicine Review Committee. And those are specialty committees. There are only 2 cardiology positions on those committees that serve for 6-year terms. So I actually replaced someone we all know and love, Dr. Minnow Walsh, on that committee. So it's a little bit of taking advantage of opportunity and positioning yourself for that opportunity. There are other opportunities on some of these organizations on ad hoc task forces, things they do when they develop program requirements, that there may be calls out for resident or fellow representatives. Often those mechanisms work through the relevant professional societies. So the route, I would say, you engage with the subspecialty societies and then with the American College of Cardiology, and then that's the connection often. Those are the groups that these organizations often look to when they need expertise in cardiology because they don't know the lay of the land in cardiology. So, on the one hand, yes, there's limited opportunity, but on the other hand, the opportunities are out there. You just have to position yourself to take advantage of them. And for me personally, it was a career-changing event when I entered the ACGME world, because when you think about it, before that, my world was focused really solely on cardiology. After that, my world was in internal medicine from an education standpoint. And then it became ACGME-International. I'm very lucky and blessed that I've had these opportunities. but it did open my world and open the possibilities for me to serve in different ways in the medical education community.
Yeah, it's been great to hear about your career and how it's unfolded and the various roles you can hold within MedEd. And there's different opportunities that might come upon at different stages of your career and even outside of cardiology, like you mentioned. Now I want to transition a little bit to talking about some of the nuts and bolts of designing training milestones and such. And you've been someone who's involved in the ACGME as well as writing various ACC training statements, and you have a unique perspective on the different stakeholders that are involved and oversee training expectation for cardiology fellowships. For our audience, would you be able to just outline who each of these stakeholders are so we can get a better understanding of how the system works and what the role of each of these stakeholders are in defining the minimum expectations for fellowship and how accrediting cardiology training programs works?
Certainly, it can be very confusing, and the various organizations that are involved, and sometimes it's not as organized as you might think. Traditionally, the roles for the accrediting body and the certifying body, the accrediting body credits the programs, the certifying body is about individual certification, ACGME and ABIM, respectively. Traditionally, they were and still are, in many ways, setting minimum standards. You have to meet a threshold to get accreditation. There's some threshold on taking a certification exam, and ultimately it's a yes or no kind of decision, right? And that's the traditional, what we call the assurance function of these organizations. I should say that over the past decade or so, these organizations, in particular ACGME, has moved accreditation into the space also of a quality improvement function, which we believe is the future of what it's not just meeting minimum standards, but what you really want to do is promote continuous improvement. In programmatic improvement, we're talking about in this context. In some ways, I guess that's what MOC would be for on the certification side. The American College of Cardiology and professional societies in other organizations really define the curriculum in a more granular sense, in cardiology sense, because it's so big and in some ways multidisciplinary. Even within cardiology, it's a very complex curriculum, but they're more granular, they're more contemporary, more specific competencies, more specific aspects of the training guidelines. And how is that manifest in the documents? Well, and we'll discuss maybe, we'll touch upon this later, maybe is the COCATS document, which is a multi-layered document, multiple levels, all this kind of thing. For the certification boards, or for the general cardiology for a minute, or for the ACGME standards, there's just one set of standards. There's not 15 different ways to get accredited in cardiology. So it's the minimum. But at the same time, the other role these organizations have taken, especially ACGME, has been the quality improvement function.
Yeah, really interesting to hear about how you think about accreditation as not just milestones, but this quality improvement initiatives. And to delve a little bit deeper into COCAS that you mentioned, this was definitely a term I heard a lot thrown around when I was recently interviewing for fellowships. And for audience, so COCAS is the most recent version of this training statement that was released in 2015 and was a departure from prior COCAS documents. Older versions prioritized the amount of time and procedural volume cardiology trainees were expected to complete prior to graduation, such as rotating for 4 months in the cath lab. And this new document placed new emphasis on competency assessment of fellows as part of determining readiness for graduation. Dr. Arrighi, can you define a little bit more for us about competency-based education and why cardiology made the decision to move towards competency-based training?
Yes. First of all, I think it's useful to think about what we mean by competency-based medical education. And you may have covered this in other podcasts, but really, in some ways, talking about it in the context of COCAS, we're talking about an evolution of medical education, a reform of such, that we're moving from one approach to another. Problem-based learning was one approach that was introduced some years ago as another reform movement in medical education. So things happen and medical education evolves. And this is a step in the evolution, contemporary step in the evolution of medical education, with, I think, multiple components: a focus on outcomes-based, defining outcomes-based competence, you look at what the end goal is, and then you work backwards from there. The construct of medical education can be sequenced in a milestones fashion. You achieve this at this targets at this point, targets, in the future, targets at the end. You optimize or tailor medical education to the individual as you view their trajectory. And then you do deliberate teaching activities or assessments. And finally, one that actually sometimes is forgotten, but it is part of the CBME system, is it also has a component that is about programmatic assessment. The information you get from competency-based medical education, although it's directed to the learner, there is information you're getting about the program and the system that can then drive quality improvement. I'll mention that again in the educational system to move it forward. Now, the last COCATS, which now is quite a few years old, was only a step in that direction, right? It defined competencies for sure, and it had some element of the sequencing, not in a very granular way, but it began to introduce those concepts. So I think it'll be interesting what the next COCATS looks like. I think it was a step in that direction, and I think the future will probably be more nuanced in terms of the CBME approach to COCATS.
I'll be curious how the COCATS will incorporate a lot of the new advanced training statements and how thoughts of what competency is on more granular levels in each of the different subdomains in cardiology and how that will influence future COCATS documents. One thing that when I think a lot about competency-based education or CBME, or one thing I hear a lot, and I'm sure you get this, is when people say competency-based medical education, I think people additionally hear right away time variable training, that those two things are what people think about a lot together. And when I say time variable training, I mean that the amount of time someone spends in training could be flexible depending on when they meet their training milestones that we're talking about, those minimum standards that we just discussed. So do you think competency-based medical education and time flexible training are synonymous? And what do you see as barriers to implementing a truly competency-based, time-flexible training program?
Yeah, in my opinion, they are not synonymous. I wouldn't use that strong a term. They're related, but not synonymous. I think that competency-based education, in my view, is more about optimizing the use of time, which is a valuable commodity, the time you have in education, optimized to the learner, optimized to what the learner's goals are, what the learner's abilities are, what the trajectory for learning is. I think that's the true power of competency-based medical education. There may be a role in certain situations for linking it to some variable time aspect. And I believe there are some initiatives actually in Canada that have been pretty progressive on this, especially in the GME space. But I think their data have shown actually that for individuals in some of the real, what I would consider truly CBME approaches to graduate medical education, the vast majority of learners in those programs haven't chosen to graduate early, quote unquote. They've chosen to take advantage of their time in other educational aspects. And then, frankly, we also have to remember there are practicalities to this, not just in the United States, but in the world. I find this interesting, what I'm about to say, both in the United States, where obviously our system, to be frank, right, is based on residents and fellows being a workforce. They are a workforce. The funding is based on at least the Medicare funding is based on expectations of workforce in the hospital even, right? I mean, it's an old system, but still exists. So, but interestingly, that's also true in less well-resourced countries, in developing countries that are developing GME. Their residents and fellows are vital workforces. Also, the tension in the system that if you begin to think about time variable training, you have to think about how it affects the workforce. You're kind of a balance between a student and an employee or caregiver, even at different levels. So time-based training has implications on funding. And I think that if we wanted to truly move to a time variable system, we would need CBME, but then you need to intentionally redesign the whole system, which probably is not on the horizon over the next years ahead in the US.
Yeah, I don't see that coming up quickly anytime soon. I think still even talking a little bit about exposure to the broad area of cardiology and gaining competence in areas, or at least even still meeting the COCATS requirements. There have been prior surveys of cardiology fellowship programs that have found that really only a few of programs are able to offer or expose their fellows to the entire breadth of cardiology. So, for instance, a fellow may be interested in one area of cardiology and really only have limited exposure, something like amyloid or cardiac oncology being two examples that I can think of. So, if you've had a fellow who's coming to you and said, they had an interest in a specific subspecialty, how could they find exposure in their general fellowship if it's not available at their training institution? And I think the second question always is who should pursue additional subspecialty training beyond the traditional 3-year training program?
That's a great question, and it can be a difficult one to answer for the individual fellow who seeks training that may not be readily available. I do think this is one of the several things that post-COVID may actually be a little easier to solve the problem, or at least may present some solutions which are more acceptable. It used to be years ago, as a program director or even in other positions, you used to think you have to try to provide everything locally. And if you seek connections with outside sources of information to provide education for your fellows, that's a failure. Now it's the norm, right? Now, or it's not the norm. It's certainly, maybe we were forced to do it, but it's opened up possibilities. And frankly, I think a lot of it was because of what we had to do during the pandemic. But I do think the attitude among us has changed to say, actually, it makes more sense for programs to share resources potentially, within whatever limits there are, either the technical limits. There might be in large cities, there are multiple cardiology fellowships within the same city where there's no reason why these solutions to these problems can't be at hand. So some of it is on us, the medical education leadership, to design opportunities for that. I have heard of some professional societies. So there is a role potentially in professional societies facilitating these kind of things, right? Providing tools. I just heard recently about the Nuclear Cardiology Society doing something to help connect mentors, remotely for fellows that might be interested, for providing opportunities for the whole radiation safety and stuff you have to do that maybe every institution doesn't have those resources, to link the fellows up with those opportunities to learn the radiopharmaceutical and radionuclide safety. And I think other societies have done similar in other domains. So I think the professional societies, the subspecialty societies can take a role. And then I think there is a level of pragmatic aspects to this that it will always be that if you're interested in electrophysiology, you should probably try to go to a program that has electrophysiology. And the converse is true, even if you don't know at all what your interests are. If you're at a program that has a very strong electrophysiology department, you may be kind of sucked into that domain. And that's all okay, right? I mean, we can gravitate towards that which we get exposed, and some of it is a little bit random. So yes, I often used to, when I was advising residents or fellows, I often used to, and sometimes, some residents would come in on like the first month of their internship and they knew they wanted to do cardiology, and others, don't make a decision until later. And I used to kid with some of the ones that came in soon. I said, boy, you're blessed with knowing so early, and we'll certainly start helping you through that. And often they really are, because they start focusing on that early, but not everybody is at that stage. So it depends on the individual, but I do think there are a lot of potential resources now, more than there were before. And I think, of course, then who eventually does training beyond a 3-year fellowship? Some of it's defined by what subspecialty you want to do. Some of it's necessary that you have to do additional years. It's just the structure. The other big category, I think, that would be in that bucket of almost necessary would be if you want to be a physician scientist, a significant research career, you will necessarily have to do more training than 3 years. But otherwise, there is a lot of flexibility with whether you make that decision or not. I don't think we should be extending training anymore at this point in time.
Thank you so much for sharing your insights. And I think COVID has definitely led to a lot of changes within education, like you mentioned, and the world has become a smaller place with virtual education and these mentorship opportunities and options for trainees and fellows. And as we've been discussing, general cardiology and other ACGME-sponsored fellowships receive oversight and accreditation from the ACGME. And talking a little bit more about these subspecialties that may not be readily available at all institutions, who should be overseeing the training and training requirements for these non-ACGME subspecialty training programs? Do you foresee each of these groups having their own certification and subspecialty boards?
Yeah, the question of oversight is a good question. So right now in cardiology, when we're talking about these additional, in addition to general cardiology, in these what we call subspecialties of cardiology, there are some training programs that are ACGME accredited, then by definition sort of will have the corresponding ABIM certification. And there are a bunch of areas that are not in that domain. Within that category, there are different, what I would consider different levels of, or different states of maturity of those specialties. So that's one dimension of the complexity of the issue. From a pragmatic standpoint, as of 2024 or maybe a 2023, the ACGME does have some role in oversight if it's actually linked. This is a little bit of an esoteric link to whether or not these programs want to sponsor fellows that require J1 visas. If they do, then they have to be what's called a non-standard fellowship training pathway at ACGME. So they have to sort of have that structure. That's a relatively new thing. That used to be under the ABMS. And most of these programs do want at least the possibility of having fellows who require visas. So most of these programs will be not in the same level as true ACGME programs, but they will have some oversight from ACGME. But the real oversight, I believe, rests with the institution, the sponsoring institution. By definition, usually the institution where these programs are have cardiology fellowships, internal medicine residencies, and other programs. There's a whole GME infrastructure at these places. It is the responsibility of the institution to ensure that these non-ACGME programs are held to some standards, if not identical to ACGME. It's in their interest to not just have rogue programs doing anything they want. They should be made to adhere to a structure. That's what we did at Brown. We actually held them to the same standards. So I believe the sponsoring institution bears that responsibility because it's a program that ultimately reflects the sponsoring institution. The question of whether or not some of these should evolve to be ACGME programs, whether or not they should be sub-ABMS examinations under ABIM, that is a difficult question because on the one hand, there has been arguably some concern about the proliferation of subspecialty exams. On the other hand, they proliferated with, I think, generally good intentions. So I think that we may be at a stage where we rethink the system. Do you need to have an exam in the same way that we do it? Do we do something in a more creative or in a different way? I don't really know. The other question I think it begs, and this is just my personal opinion, is as cardiology evolves into more and more subspecialties, to my mind, this is very much my own opinion, it begs the question, is cardiology a primary specialty that's distinct from internal medicine? Not that you shouldn't have some internal medicine prerequisites, but are we at the point where we've evolved into something that's large enough and focused enough that, again, the framework should change a bit or evolve? Some of that's happened in the surgical disciplines over the last decade, right? So I don't have the answers, but we have the questions, I think.
Yeah, I think as cardiology, what's exciting about us as cardiology continues to advance and develop, and there's new areas of cardiology continue to grow, cardiac oncology, hypertrophic cardiomyopathy, amyloid, we're becoming larger and larger, and there's more areas for people to go into and develop interest. And that's exciting, but also, like you said, it makes us such a bigger institution than we were when the COCATS 4 came out back in 2015. And I think that ties in really well because we're talking about advanced subspecialty training. And for a lot of fellows, I'm in my third year of fellowship. I think when people are considering advanced subspecialty training, there really are two poles that fellows are dealing with at that moment in time. One, like you said, is their professional goals, what they want to be as a cardiologist. And then the second is often any type of personal, family or financial obligations that they have. And one idea that I think has been made to address this kind of conflict that fellows have has been the creation of the 2+2 alternative pilot pathway for EP, which is where fellows at certain institutions are able to complete general cardiology fellowship and EP fellowship within 4 years, as opposed to the traditional 5 years. I know you were heavily involved in committees overseeing this change. And so I really like to hear you talk a little bit about this pathway and kind of big picture about what are some different organizational and institutional efforts that are really to address these competing challenges. As we become more and more subspecialized and fellows are pulled to more training?
Yeah, that's an excellent question. And you're correct. I have a particular a warm spot in my heart for the 2+2 pathway because I was one of the main proponents and leaders in the development of that proposal. First, I think that it's an exciting proposal, but with all humility, wasn't rocket science or that novel. This pathway existed unofficially, actually, for decades before it went away. And it went away when electrophysiology, in this case, officially became a 2-year program. And the concept of overlap was relatively foreign to ABIM or ACGME. I think that concept has changed. But at the time, once you say that it needs its own years of training, then the overlap wasn't in the lexicon. I think this concept of blurring transitions between phases of training is talked about in educational circles all over the place now, right? It's in even UME to GME transitions are becoming, in some places, there are some interesting pilots in the medical school level that have shortened medical school training. I hate to say just shortened, because what it really is doing is blurring transitions. That's how I like to view it. At the same time, to be very pragmatic, there's not unlimited resources. A sort of a correlate to your question about the impact on the individual, or even on the ability to attract diverse candidates into a field. The correlate to the cost to the individual is the cost to society, right? The longer folks train, the more it's resources that need to be put into that. So I think these concepts of overlapping training that are arguably more possible during the competency-based medical education era are the future, because it solves some practical questions and problems, and it may have many other positive benefits. I realize that in the context of everything getting more complicated, some could say that, you're taking training away. Will the person be prepared for practice once they finish? In that sense, though, you could carry that argument and you'd end up with continually adding years to training. I think that's not necessarily the solution. The solution is we need to think about more efficient ways for training. So I think, and I hope, I'm speaking for myself, that the ACGME and ABIM are receptive to doing this kind of thing without such a burden of having these complicated pilots or long pilots, because I think that model would make perfect sense in adult congenital heart disease. Maybe in heart failure, there's a lot to learn in only a year, but maybe it's a 3.5-year program. I don't know. Cardiac imaging, maybe. Interventional cardiology, for those that want to do other things other than just coronary interventions, would probably take more than a year. This would be maybe a good 2+2 for interventional cardiology. I'm not being asked for advice by the ACC, but I think they should promote those kind of initiatives with the relevant societies and organizations.
Yeah, and I really like how you use the term blurring transitions rather than shortening training to help with efficiency. I think it gets at the core of the evolution of training pathways, and it'll be interesting to see how other pilots come about in other subspecialties. And transitioning a little bit to your current role, we discussed at the start of this discussion that you currently serve as the president and CEO for ACGME-International. And through this organization, you're involved in ensuring a high standard of trainee education globally by accrediting international training programs. Now, I envision that this is a challenging task as the organization needs to develop training milestones and expectations which can be adopted by a broad range of different healthcare systems and cultural norms. Can you tell us a little bit more about your work with ACGME International, including some of the challenges with international accreditation? And does accreditation through ACGME International play any role in a trainee's ability to transition from a non-U.S. program to a U.S. graduate medical education program for advanced training?
Yes. Thank you for asking about ACGME International, which is my current passion. First of all, we have to recognize that the ACGME International experience at present is, when you think of the world, is relatively small, is relatively narrow. We're currently operational in 12 countries. We have about 23 sponsoring institutions. So, relative to the United States, I think there are 900 or 800 and something sponsoring institutions. So our experience is, on the one hand, limited, and they tend to be in institutions that are on either the forefront of medical education or have intentionally designed their programs more or less according to the U.S. framework. Because there are many other valid frameworks out there for PGME, although some countries don't really have an established framework. So some systems might be modeled after the US, some at the UK, some at Canada. There are different systems. We're just one system. But a framework to postgraduate medical education, as it's called outside the US, is important. So some of what we do is we provide that framework to those that are attracted to the US framework. And that said, you are absolutely right that the context in which we apply it, even though I just said we're in 12 very different countries. And in each of these institutions, they're at different stages. We're engaged in some places that have had GME training programs for decades and very mature programs. Others are just starting. So we have to apply our processes and standards in a way that is appropriate to the context, culturally sensitive, that recognizes even things like variable differences in scope of practice in specialties. What we've done, we've been in existence for 15 years. I would dare say that initially it was viewed as a relative experiment about whether this kind of a thing could be done. I think we've proven that it can be done. And the reason it can be done is probably because our requirements are relatively context nonspecific, have some flexibility built into them. The milestones, similarly, we went through a developmental process for our most recent milestones, asking the international community whether we should adopt the US milestones, modify them to their needs. And there was unanimity that said, no, these are appropriate for us too, which presents a lot of possibilities, by the way. It means the milestones, kudos to the version 2 writers of the milestones in the US, wrote them in a context nonspecific way. I think we're proving it's still a work in progress, but I think we're proving that they can be useful. Now, on the connection to the United States, which actually isn't the mission of ACGME-International, ideally, our goal is to improve the healthcare systems in the countries in which we serve, and then it will improve their workforce. In 2024, though, one of the hot topics is physician mobility, I like to say. Physicians, first of all, you have the right to move around the world and practice where you want in theory, once you meet the requirements of the country or the jurisdiction, but also workforce needs across the globe may necessitate physicians moving around. And they may want to do that. And this includes in the United States. Some of you may be aware of a lot of activity on state licensure boards now talking about whether to and how to license physicians trained outside the US, perhaps without repeating residency or fellowship here. It's a work in progress. So all of a sudden now the ACGME-International is drawn into that conversation because we are engaged with programs out there that to the world that looks a lot like a US program. It's the same general framework. So I think this is in a work in progress. What I can say that's very clear is that the eligibility requirements for fellowships in the US in all specialties except neurosurgery recognize ACGME-International residencies as an entry criteria. Whether that qualifies them for certification or not is up to the certification boards. I think they make their own decisions in the US independently. But we are seeing now that the existence of ACGME-International programs being recognized in the United States, the residencies, say in internal medicine in this case, for some fellowship programs they're starting to get residents from these programs and these connections begin to form. So we are starting to see that the existence of ACGMEI is beginning to bridges.
I think like what you're talking about is really exciting because it proves again to your point that these milestones really are set up to help drive quality improvement initiatives in programs. And it's exciting to see that it's not only going to help with quality improvement initiatives in the United States, but we're talking about on an international scale, how the milestone writers wrote it. So that I think really speaks a lot to what the ACGME and their milestones have been able to do and the future where they can further drive program development. You have had a lot of different roles in your career, and we've touched on quite a few of them as program director, director of graduate medical education. I think from your experience in those roles, and even now with the ACGME-International, what are ways that you think we can work to help better diversify our workforce within cardiology, especially in terms of recruiting a more diverse training class?
I think that the issue around diversity in cardiology is probably appropriately always linked to pipeline issues because we are, by definition, a relatively terminal phase of formal education. And there are initiatives in cardiology related to trying to improve the pipeline, meaning get individuals at levels in high school and college who are interested in getting into medical school. There are a lot more medical school positions open now, by the way, than there were a decade ago. So I think there is opportunity, and there are medical schools and communities that would be more likely to attract a more diverse medical student population. And then we need to get to that level and begin to encourage those individuals to enter the pipeline. And I think that Even a terminal specialty, subspecialty like cardiology and other similar specialties in other areas of medicine have important roles. Each specialty has an important role in trying to help contribute to that pipeline. So I think we can't just say we're a terminal educator. There's nothing we can do about it. I think there's a lot we can do about it. And I think the most important thing we can do about it is trying to improve the pipeline. Some of these other things we talked about in terms of improving the educational milieu will help. I mean, anything you do that helps make the clinical learning environment more fair, more humane, eliminates, or it will never eliminate, but eliminates the bias, unfair treatment, all those things that exist in the clinical learning environment. But to minimize that, those will all help to a degree. And that's something that is in the ACGME space and in the space of GME leaders at their institutions. But in addition to that, I think working on the pipeline and getting kids interested in medical career is key.
Thank you for sharing those insights. We talk a lot about that leaky pipeline within cardiology and within CardioNerds and other professional societies. And I think one of the goals of our narrative series has been to make people more comfortable asking others about what makes them different and promoting diversity inclusion within the field through those conversations. So we are really, really grateful to have you here with us today. And this discussion has been such an amazing conversation, and we really appreciate your time. One thing that we ask all our guests on the show is what makes your heart flutter about cardiology and graduate medical education?
Great question to end on. And I would say innovating. When I hear things that have always been done a certain way, and then there's a new idea that pops up, which often comes, by the way, from a trainee or a student, but we older folks can have new ideas too. That's the thing that I say, wow, that could be a source of excitement, of course, a source of doing something different. I mean, one of the reasons I was attracted to go back to the first questions about attraction to the career and a career as a clinical educator is because there's variety, there's innovation. I guess you could think about that no matter what you do, but you have your hands in so many different things. And so I think it's the innovation, listening to new ideas. That's the thing that is exciting about the work.
I think that's a great note to end us on, innovation within medical education. And it's been really inspiring as someone interested in education to see your passion for the fields and how you've really evolved in your career with the different leadership opportunities and different ways that someone can get involved in education within cardiology. So thank you so much, Dr. Arrighi. We really appreciate your time, and thanks for spending some of it with us on CardioNerds today.
Thank you for having me. It has been my true pleasure.
Thank you for tuning in to this CardioNerd episode. The audio and editing for this episode was performed by me, Atefe Qurbanzadeh. I'm an intern in CardioNerd Academy House in Pullman and a research fellow at the Mayo Clinic. I invite you to check out our website for show notes and references. If you find this episode informative, please consider subscribing to CardioNerd on your favorite podcast platform and leaving us a review. It really helps us spread the word for our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views and expresses on our show and site do not reflect the opinion or policy of our employers. All CardioNerd content is planned, produced, and reviewed solely by CardioNerd. Stay tuned for more engaging conversation and exploration on our upcoming episodes. And now, it's time to make like S2 and split.